Today, we are diving deep into Adrenergic pharmacology. We're going to explore the drugs that literally tap into our fight-or-flight response by interacting with the sympathetic nervous system. We'll cover the whole story, from the molecules themselves all the way to how they're used in the clinic. So, let's get right into it.
So here's our roadmap. We've split this masterclass into 6 parts. First, we'll get to know the key players, the catecholamines and the receptors they bind to. Then we'll see how that signal gets transmitted, and just as importantly, how the body keeps it all under control. After that, we're going to follow the complete life story of noradrenaline. And finally, we'll get to the drugs themselves, the agonists that mimic the system, the antagonists that block it, and a fascinating group of indirect agents, which is where we'll also take a special look at dopamine.
All right, let's kick things off with Section 1, catecholamines and their receptors. Before we can really get a handle on how the drugs work, we've got to understand the body's own chemical messengers and the targets they're aiming for.
So, first things first, what is a catecholamine? Well, if you look at its structure, it's an aromatic amine that has 2 essential parts. A catechol ring, that's just a benzene ring with a couple of hydroxyl groups on it, and an ethylamine side chain. Now, there are 4 key ones we really need to know. We've got noradrenaline, which is primarily released from sympathetic nerves. Then there's adrenaline, which comes from the adrenal medulla. We also have dopamine, which is interesting because it's not only a precursor to noradrenaline, but also a super important neuromodulator in the brain. And finally, there's isoprenaline. Now, this one's synthetic. You won't find it in the body, but it's absolutely essential for understanding the pharmacology.
Okay, so these catecholamines don't just act randomly. They hit specific receptors, which are mainly grouped into alpha and beta types. The way they were first classified was actually pretty simple. It all came down to potency. For alpha receptors, the order of strength is noradrenaline, then adrenaline, and then isoprenaline. But for beta receptors, it's the complete opposite. Isoprenaline is the most potent, followed by adrenaline, and then noradrenaline. And this brings us to a really crucial point. The effect a catecholamine has totally depends on its concentration. Take adrenaline. At low concentrations, it prefers beta receptors, but if you crank up the concentration, it starts hitting alpha receptors. Dopamine is even more of a specialist. At low doses, it sticks to its own D receptors. At moderate doses, it starts targeting beta receptors, and at really high doses, it acts on alpha receptors.
This diagram here lays out the different jobs that each receptor subtype does. Let's start with alpha-1. These receptors use GQ proteins, and you can think of them as being all about contraction. They tighten up blood vessels, the bladder sphincter, and the uterus. Then you've got alpha-2 receptors. These use GI. The I is for inhibitory proteins. Their main job is to put the brakes on things, like stopping further noradrenaline release and cutting back on insulin secretion. Now for the beta receptors. All of them, beta 1, 2, and 3, use GS, S for stimulatory proteins, to ramp up a molecule called CAMP. Beta 1 is the heart specialist. It increases heart rate, conduction speed, and the force of contraction. It also tells the kidneys to release renin. Beta 2, on the other hand, is a relaxer. It opens up the airways in your lungs, relaxes the uterus, and dilates blood vessels. And finally, there's beta 3. It acts on fat cells to promote fat breakdown, and it also relaxes the bladder muscle.
So, we've met the key players. Now, in Section 2, we're going to dig into how they actually get the job done. We'll explore the signaling cascades they set off inside the cell and, this is critical, how the body regulates this incredibly powerful system to make sure it doesn't just go completely haywire. Every single adrenoceptor sends its signal using this really elegant mechanism called the G-protein cycle. Let's walk through it. So, step 1. In its resting, inactive state, the G-protein's alpha subunit has a molecule called GDP bound to it. Then, an agonist comes along and binds to the receptor, which causes the receptor to change its shape. This change prompts the G-protein to literally kick out the GDP and grab a GTP instead, which activates it. Once that happens, the activated alpha subunit breaks away from the beta-gamma complex. Now you've got 2 active pieces, the alpha part and the beta-gamma part, and both can go on to activate downstream effector proteins, which carries the signal forward. But the system has a built-in off switch. The alpha subunit eventually hydrolyzes that GTP back to GDP. This inactivates it, letting it reconnect with the beta-gamma complex and resetting the whole system, ready for the next signal to arrive.
So what happens if a receptor gets stimulated over and over and over again? Well, the body has a way to protect itself through a process called desensitization. The result of this is something called tachyphylaxis, which basically means you get a rapidly diminishing response. This diagram shows us exactly how this works for beta receptors. When an agonist binds, an enzyme called GRK comes in and slaps a phosphate group onto the receptor. This phosphate acts like a little flag for another protein called beta-arrestin. Beta-arrestin then binds and physically blocks the G protein from interacting with the receptor, effectively silencing the signal. But it doesn't stop there. Beta-arrestin then drags the whole receptor inside the cell into a little bubble called an endosome. From there, one of two things can happen. It can get dephosphorylated and recycle back to the cell surface, ready to go again. Or, if the stimulation just keeps on coming, it gets tagged with ubiquitin and sent to the lysosome to be destroyed. This physical removal of receptors is what we call downregulation.
Okay, now let's zoom in and focus on the star neurotransmitter of the sympathetic system itself, noradrenaline. In this section, we are going to follow its entire life cycle, from the moment it's created to the moment its signal is terminated. And trust me, understanding this pathway is absolutely critical because so many adrenergic drugs are designed to interfere with it.
This diagram right here gives us the entire process at a glance. It all starts with the raw material, an amino acid called tyrosine, entering the neuron. From there, it gets synthesized into noradrenaline and then carefully packaged into storage vesicles. When an action potential comes along, it triggers the release of noradrenaline into the synapse, where it can then act on receptors. And finally, its signal gets switched off when it's taken back up into the neuron. Now let's break down each of those stages in much more detail.
Let's really break this down step by step. First up, synthesis. This is a multi-step process. It all begins when the amino acid L-tyrosine is transported into the neuron. The enzyme tyrosine hydroxylase then converts it to L-dopa. This is the rate-limiting step, the bottleneck of the whole process, and it can be blocked by a drug called alpha-methyltyrosine. Next, another enzyme, dopa decarboxylase, converts L-dopa to dopamine. This is the step blocked by the drug carbidopa. Then, dopamine is pumped into vesicles by the vesicular monoamine transporter, or VMAT for short. Inside that vesicle, the enzyme dopamine beta-hydroxylase converts dopamine into noradrenaline. And only in the adrenomedulla, there's one final step. An enzyme called PNMT converts that noradrenaline into adrenaline. Okay, next is storage. Noradrenaline is packed into these vesicles by VMAT, and the drug reserpine works by blocking this exact transporter. Third, release. When an action potential arrives, it opens up voltage-gated calcium channels. Calcium floods into the cell, which causes the vesicles to fuse with the cell membrane and release their noradrenaline. Fourth, regulation. There are presynaptic alpha-2 receptors that act as a negative feedback loop. When they sense noradrenaline in the synapse, they send a signal to inhibit any more from being released. And finally, termination. The signal has to be turned off. About 75% of the noradrenaline is taken back into the neuron by the norepinephrine transporter, or NET. This is the target for cocaine and tricyclic antidepressants. The other 25% is taken up by other nearby cells through the extraneuronal monoamine transporter, or EMT. Once it's inside any cell, it's broken down by two key enzymes, monoamine oxidase, MAO, and catechol-O-methyltransferase, or COMT.
And now, we get to the pharmacology. In Section 4, we're going to look at adrenoceptor agonists. These are the drugs that either mimic or enhance the effects of the sympathetic nervous system. We can group them into three types: direct acting, which bind right to the receptor; indirect acting, which work through other mechanisms; or mixed acting, which, as the name suggests, do a bit of both.
Here are some of the key direct-acting agonists. Phenylephrine is a selective alpha-1 agonist. You've probably seen it in nasal decongestants, where it causes vasoconstriction in the nasal passages. Clonidine is an alpha-2 partial agonist. It actually works in the brain to decrease sympathetic outflow from the central nervous system, which makes it a really effective drug for high blood pressure. Dobutamine is mainly a beta-1 agonist, and we use it to increase heart rate and the force of contraction, especially in cases of cardiogenic shock. Salbutamol is a famous one. It's a beta-2 agonist used in inhalers for asthma because it causes bronchodilation, opening up the airways. And finally, we have mirabegron, a beta-3 agonist that relaxes the main muscle of the bladder, the detrusor muscle, and is used to treat overactive bladder.
These graphs are just a perfect illustration of how a drug's receptor selectivity completely dictates its effect on the body. Let's start with noradrenaline. It's a potent alpha agonist, so it powerfully constricts blood vessels. This dramatically increases peripheral resistance and, as a result, shoots up both systolic and diastolic blood pressure. The body tries to compensate for the sharp rise in pressure with a reflex slowing of the heart rate, something we call reflex bradycardia. Now, in total contrast, look at isoproterenol. It's a pure beta agonist. It dilates blood vessels, which causes peripheral resistance and diastolic pressure to plummet, while at the same time it directly stimulates the heart to beat faster and harder. And then there's adrenaline, which hits both alpha and beta receptors. It has a mixed effect. Its beta-2 action lowers peripheral resistance, while its powerful beta-1 action jacks up the heart rate and systolic pressure.
Let's just zoom in for a second on exactly how this works inside heart cell. When a beta-1 agonist binds to its receptor, it increases the amount of intracellular CAMP. This in turn activates an enzyme called protein kinase A, or pKa. pKa then goes around phosphorylating several key targets. It hits L-type calcium channels, which increases the flow of calcium into the cell, leading to what we call a positive chronotropic effect. That's a faster heart rate. It also targets ryanodine receptors and a protein called troponin, which together increase the force of contraction. That's a positive inotropic effect.
All right, let's move to the other side of the coin, the antagonists. Section 5 is all about the drugs that block adrenal receptors. These blockers, as they're often called, are therapeutically vital for opposing the actions of the sympathetic nervous system, particularly when it comes to cardiovascular disease. The most important concept here is selectivity. For example, prazosin is a selective, reversible alpha-1 antagonist that's used to lower blood pressure. You can contrast that with phenoxybenzamine, which is a non-selective, irreversible alpha antagonist. It's a similar story for beta blockers. We have propranolol, the classic non-selective beta antagonist. It blocks both beta-1 and beta-2 receptors. This is very different from atenolol, which is selective for beta-1 receptors. That selectivity makes it cardioselective and much safer for patients who also have asthma. And then you have drugs like labetalol, a mixed antagonist that blocks alpha-1 and beta-1 receptors, but is also a partial agonist at beta-2 receptors, giving it a really unique profile for treating hypertension.
So how exactly do beta blockers bring down blood pressure? Well, they work in three main ways. First, they block beta-1 receptors in the heart, which directly reduces cardiac output. Second, they block beta-1 receptors in the kidney, which cuts down on renin release and dampens that entire blood pressure regulating system. And third, they have a central action in the brain that reduces the overall sympathetic outflow. But, and this is a critical warning, when you use these drugs chronically, the body responds by making more beta receptors. If you then stop the drug suddenly, all that adrenaline can hit all those new receptors, causing a dangerous spike called rebound hypertension.
Okay, in our final section, we're going to cover drugs that have more complex, indirect ways of working. We'll also circle back to the unique pharmacology of dopamine.
Dopamine is truly one of a kind because its effects are completely dose-dependent. At low doses, it stimulates T1 receptors, which causes vasodilation specifically in the renal blood vessels, improving kidney function. At moderate doses, it starts to stimulate beta-1 receptors, increasing the heart's contractility. And at high doses, its alpha-1 effects take over, causing widespread vasoconstriction. This dose-dependent profile makes it really useful in cardiogenic shock. Of course, it has adverse effects, like tachycardia and hypertension. And a huge warning, it must never be used in patients who are taking monoamine oxidase inhibitors because that prevents its breakdown and can lead to a hypertensive crisis.
Now for those indirect agents that mess with the noradrenaline life cycle, we can group them by what they do. First, we have drugs that affect synthesis or metabolism, like alpha-methyl-dopa, which gets converted into a false neurotransmitter, or selageline, an MAO inhibitor. Next are the storage inhibitors, like recepine, which blocks the VMAT transporter and basically drains the vesicles of their noradrenaline. Then we have the uptake inhibitors, like cocaine and the antidepressant imiprine. They block the net transporter, which causes noradrenaline to pile up in the synapse. And finally, there are the uptake analogs, like tyramine, which sneak into the neuron and actually push noradrenaline out of its vesicles.
Let's take a closer look at how those uptake analogs like tyramine actually work. In the short term, tyramine gets transported into the nerve terminal by NET, and then into the vesicles by VMAT, where it physically displaces noradrenaline. This shoves the noradrenaline out into the synapse, causing a short-term sympathomimetic effect, a sudden burst of sympathetic activity. Chronically, however, this same process can eventually completely deplete the neuron's stores of noradrenaline.
This slide highlights a really key difference in the side effect profiles of these drugs. The ones that interfere with neuronal function, the ones blocking release and storage, they tend to cause issues like orthostatic hypotension, which is dizziness when you stand up, along with nasal congestion and sedation. In contrast, the receptor blockers present a totally different set of problems. Alpha blockers can also cause orthostatic hypotension, but often with a reflex tachycardia. And beta blockers can be risky for some patients. They can potentially trigger heart failure, cause increased airway resistance, or even mask the warning symptoms of hypoglycemia in diabetics.
We have covered an absolutely immense amount of detail today, from the intricate dance of G-protein cycles to the entire life story of a neurotransmitter. It really just goes to show how complex and how finely tuned this system is. And that leads us to a final thought. As our understanding of all the subtle differences between the various adrenoceptor subtypes and their specific signaling pathways continues to grow, what new, more targeted, and more effective therapeutic possibilities might just be on the horizon?